As Alyssa mentioned, I'm Justin Baker. I have met so many of you over Zoom, and it's really interesting because I think you immediately in Zoom feel like, oh, that person's like 6'4" or 5'7", and then you meet him, you're like, huh, you are different than I expected, and so I'm sure, and you're meeting me, you're like, huh, you're different than I expected, but. As my daughter says, I can't lose weight because then I wouldn't look as much like a koala as I do right now. So that's one of the main issues there. So one of the other roles that I actually will have, and I'm so excited to work with family-centered care and with many other providers, I'm going to be the Associate Chief Quality Officer for Patient Experience and Holistic Care. So as we think about the big picture of our experience for our patients and families, we have a real opportunity by integrating palliative care to make a difference in their lives, and then also hopefully through this role be able to do that as well. So as we get started, I like to start every talk that I do with a patient story, and I have a video that I want to share with you. This video is done out of St. Jude. I spent 20 years at St. Jude. I started our program at St. Jude, and we've been able to do a lot of really innovative and interesting things in the context of pediatric oncology. And I'm really looking forward to seeing how we can expand those concepts and think about those in new ways in each of your areas as well. And so as we go forward and think about this, you'll get to meet Jessica, Shadow, and this is my team back at St. Jude, and our team here will be making a video such as this hopefully very soon with some of our patients. But you'll catch the concept. We want to set the tone for the talk today.
When I think about Jessica, I am immediately reminded of her smile. You would walk in the room and right away you would know what her mood was. And boy, when she was in a good mood, that smile would light up the room. And boy, when she was not, she would let you know.
You couldn't meet Jessica and not remember her. She loved the staff. She loved entertaining. She knew she had a gift for making people feel good, and she loved to use that gift.
She was always full of life. She loved to joke. Oh, she was a Florida Gator fan. For the art teen show, she made a poster with the Florida Gators that was chomping up the cancer.
She believed in her heart of hearts, as did her parents, that she would absolutely be cured. And it was with that spirit, that spunk, that larger than life attitude she approached every day. Then when the tumor started coming back, it just came back raging. At that point, there really was very little that we could do to control it, certainly not cure it.
As it became more and more obvious that she wasn't going to be out of the hospital for the remainder of her life, it was all about how can we make these days brighter for her.
Jessica asked if she could have a puppy from the Make-A-Wish organization. Having a puppy in an inpatient setting is not a simple feat.
Anytime you enter an animal into this environment, there are so many things that have to be done.
We can't just break every rule and say, okay, well, let's bring the dog in.
You have to think about people with allergies, people who don't like dogs.
The fact that we have other patients here too.
Where's the dog going to be? Where's he going to stay?
Who's going to be responsible for the dog?
But with all that consideration, how can we make it happen?
Just to make that one event happen, so many people have to be involved in that.
No matter whether it's infection control, nursing, environmental service, security, everyone gets together and we come with the blueprint. It was our job to make sure we were ready.
We went over to the outside gift shop and we found these flags that go on the car. We bought one of those. I took it home and designed it to make it into a vest.
When he came in the door, his tail was wagging, his nose was up in the air, didn't show any signs of anxiety. Once we saw the personality of the dog, we knew that he was going to be a good fit. We knew that everything was going to be all right.
Shadow came and had his vest and had his badge and came through so smoothly through security and made his elevator ride up to the floor and enter Jessica's room.
They take Shadow over to the bed and she was kind of groggy and she wakes up and she says, I love you. And she touched his head and then he laid down.
The initial meeting between the two of them was just like it was just supposed to have been that way. It was just amazing.
She was so excited and the room was so full of joy.
She was going to be able to sleep that night with that one major dream fulfilled.
It was sort of this triumphant moment of all of these things that we've done, which may seem minor, all came together in this one moment where you realize that everything was worth it to give her this incredible wish come true at the end of her life.
Shadow made a huge difference. I mean, a huge difference in Jessica. She suffered tremendously, and Shadow would crawl next to her and be a source of support. And so seeing the difference that Shadow made, you immediately knew that it was not only the right thing to do, it was the perfect thing to do.
It's hard as a physician, as a scientist, to sometimes say that there are limits to what we can do with the tools that we have. Shadow was actually almost like part of the medical team. He was able to help us give her some of that comfort and achieve more than what our medicines could offer.
Jessica knew that she was dying and she wanted to leave her parents something that they could tangibly have of hers. And that was her wish.
Shadow is playful. He loves to play hide and seek. He loves to chew on empty water bottles and make them squeak and run and slide, and it makes them laugh. There's a lot of Jessica's personality in Shadow.
It's hard to describe the love that was in the room, but you could see how much it meant to Jessica, and you can see how much it meant to her parents.
I really think that that's what this place is all about. That's what St. Jude is all about. It is certainly about finding cures and saving children, and that has to be what we're emphasizing. But at the same time, it has to be about making every day the best day it can possibly be for every child. In this case, the way to do that for Jessica was by helping Shadow come and be a part of her life. Being a part of her family for those last days of her life made all the difference. And I'm so grateful to have been a part of it.
We all have stories of patients like Jessica, and I'm so grateful to have gotten to care for her, and can't wait to be able to one day, Lexi, start caring for patients here if we can ever get through the licensure process. Anyway, that's an aside. So this is our team. Our team here, I will introduce in just a moment. This is our team at Halloween last year, and these are not mice. They are a koala outfit. So if you see us walking around in our koala onesies, please don't call us mice. We are koalas. Look, there's a koala, all these things. And koala stands for quality of life for all. And when we think about these forms, you can see I don't spare my family from the koalas either. This is my family with our ugly Christmas sweaters. This is our Christmas tree full of koalas. Like, there's a theme, right? I mean, there's a little bit of a theme here. And when you think about palliative care, it literally means to cloak or to cover. It's an extra layer of support. And compassion is another word. We're going to focus on compassion. Does anybody here know what compassion means? Like, what the breakdown of that word is? Okay, with passion is close. No koala, sorry. Anybody else? So compati means to suffer with. What a privilege we have to suffer with our patients and families. It's literally what we're called to do, provide compassionate care. And as we think about suffering with our patients and families, this is what I want you to think about when you think of us putting these silly costumes on. It's not just about that. It's really about providing quality of life for all these precious kids and their families. And when we think about the concept of suffering, suffering is the disease that we attend to in palliative care. Who knows, this is not going to be for a koala, by the way, but who knows what this is, this painting? Yes? Yes, by Munch, right? And do you know who his muse was? That's right. It was me. This is really embarrassing when I give a talk like this and I'm wearing that same outfit. So I feel pretty proud today that I don't have that sweater on. But anyway, when we think about this, we have to ask ourselves, how do we best attend to suffering? And this is a very cool museum to go to in Oslo, Norway. I was speaking about palliative care in Oslo and got to see screen. And when you think of the disease of suffering, how is it that people suffer? Just holler some things out. What does suffering happen in medicine? When you think about suffering in medicine, what are some ways that people suffer? Pain, good. Fear, good. Sadness, good. What else? Loneliness, excellent. Anxiety. Hopelessness, good. What else? Uncertainty, loss, good. Great. Well, interestingly, this Eric Cassell, and if you haven't read this, The Nature of Suffering and the Goals of Medicine, it's fantastic. And this is really before palliative care was a robust field back in the mid-'80s. And he talked about suffering as anything that affects the intactness or integrity of the person, if that is threatened or disrupted. And it is completely individual. And so when we think about this concept, Cicely Saunders taught us about total pain. I want us to think about total suffering. You all just described it. So total suffering, yes, physical, psychological, social, cultural, spiritual. We have to be able to address that. There's not a single person in here, and no person that's ever lived, that could have addressed this whole thing. This is why we have to take this team-based approach, interprofessional approach. We have to look at all of these different angles and address things holistically. All right, this one actually, there is a koala on the line for this one. What are the most important palliative care tools that we have if we think about attending to suffering? These are really highly sophisticated, and what are they? Oh man, let's see, who said that listening first over here? Oh yes, Kate, I'm so glad you said it, Kate. I was hoping that you would get that. That was good, there you go. So yes, so our ears, and this is pretty cool. So when I grow up, I want to be like Mark Nepo. Mark Nepo is actually a palliative care philosopher. So he just waxes poetic about things in palliative care. But listen, he says we need to listen with an openness, a willingness to be changed by what we hear. It takes a humble curiosity. We talked about it. It also takes a compassionate and soft heart. And it takes a team. Not a single person can address all of these issues. So it takes a holistic approach. And one key concept is that it is integrated and integrated throughout. There is not a palliative phase. I'm sorry, that almost made me sick. There's not a palliative phase. And when you say phrases like that, it helps us realize that, okay, no, we have to be integrated throughout, right? And that's integrated, yes, as a subspecialty team, like we're going to introduce ourselves, but also all of us have to be better at integrating palliative care concepts. And we really need to integrate it throughout the illness trajectory. And we at St. Jude were able to create something called Pediatric Palliative Oncology. We really kind of created this space that lives between subspecialty palliative care and subspecialty oncology. I am an oncologist. I'm a recovering oncologist, but I am an oncologist. And this space right here, just imagine nephrology I saw in the house. So maybe we think about pediatric palliative nephrology, or endocrinology, pediatric palliative endocrinology. So how do we think about this full integration, even to the point of training? This is a training program that we created that was a combined training program in hem-onc and palliative care. And we hope to do that in critical care and palliative care. We hope to do that in integrative medicine and palliative care. We hope to do all of this. So then you should ask the question, does integrating palliative care make a difference? All of us in the front row are offended by your question, but anyway, we will tell you that actually the evidence is not terrifically strong. However, I'm really grateful. In fact, most of the papers I'm going to allude to in here, I've been able to be a part of. We've had a really robust research experience. And I think that as we're moving the field forward, we're starting to recognize that it does seem that palliative care actually does make a difference. Now, again, there's evidence and there's things published in the journal of things I already knew, right? Like being a good person as a doctor, do we really need to publish that makes a difference? Probably not, probably not. So we're going to talk about some of these concepts that are already obvious. So first of all, what we see in this systematic review that we conducted is that there is an increase in subspecialty palliative care over time. There are improvements in symptoms, and patients were more likely to have a meaningful moment at the end before they died. We also recognize that the child's dying place has been in a good place, and are more likely to have a peaceful death. This is a really interesting study. This is one we did at St. Jude, where we found that patients that were involved longer with the subspecialty palliative care team had less intensive procedures, were less likely to die in the ICU, and that they didn't die sooner. So I think that's a really important finding, and that there was increased patient and family satisfaction. Also, we found that caregivers endorsed improvement in their own quality of life and decreased caregiver burden. And interestingly, when palliative care teams are involved, people felt like their primary team actually also listened better. I think that's pretty cool. So yes, we may not have randomized controlled trials yet to demonstrate this, but yeah, we're seeing that across time. How cool is that, by the way? I mean, really, like that was, I need to pause to say that felt really good. We are seeing increasing palliative care making a difference. So when you think about palliative care, though, a lot of times people are like, oh, our palliative care team, and we've got this great program, but most of the time people are just talking about the top of this pyramid, which is a consult service. This consult service means you volt us, which I learned yesterday, volt was both a verb and a noun. So you volt us and we will come, we will answer your questions, and we will try to address that issue. That takes tremendous resources and impacts a small number of patients and families. What we need to be doing is thinking about this on a tier here. So Becky, I'm thinking about your patient population. I come and meet with you and you say, you know what, in working with Lexi and working with you, Justin, I think these are the patients you should meet just as a part of our process. Oh, okay, great. And do we need a full consult, or do we have kind of a standard operating procedure? So we work on that with you in advance, and then we proactively integrate into a patient population here. And I'm going to go into that a little bit more at the end. And then finally, this last component is really how we think about resources, policies, and education, like we're doing right now, to elevate the floor of palliative care at Lucille Packard and at Stanford. So when we think about this is another key concept. What are some words that bother you? Do you guys have words that bother you? I have some that bother me. You saw me kind of almost choke up when I talked about the palliative phase, or there's others that I can't even say, like nothing more we can do. So phrases like this, but what are some just general words that bother you? I'll give an example, like moist. Is that a word that bothers you guys? It kind of bothers me. Is there another word that bothers you guys? Well, I'm going to tell you one that I think is going to bother you, but it's going to like stick because I'm doing this. We want palliative care to ooze, ooze out of the pores of Lucille Packard. We want all of us to become more and more palliative centric. And the way that we do that is through this work that we're talking about now, and through all of us learning, through integrating into the educational programs, Becky, through integrating into each of the clinical services, through integrating Kim into the research paradigm and into the mechanisms that we have going on. And we do that. This is an example of what you could think about at diagnosis, disease, crises, relapse, end of life, bereavement. And these are standard operating procedures that we might contemplate using. And this could be in any number of patient groups, not only oncology, not only nephrology, not only complex care, but we have to think about this. And this is why we're going to take this approach on almost a unit by unit basis, and thinking with our team, with your team, how can we best integrate these issues throughout? But this talk is really also about how to help you become better at providing palliative care. And so I'm going to show you some evidence in these arenas that demonstrate that you can make a profound difference in your patients and families. And so this is our first step that I'm able to be a part of with you all at elevating that floor, okay? And the one thing that I want you to get out of this next section is that suffering, as we addressed, can best be attended to through humble curiosity and holistically providing compassionate care. That's why we focused on those topics, because each of us, if we think about this, humble curiosity and holistically providing compassionate care, we all can do a better job. So the first key concept is communication. The things you say and the things you don't say matter tremendously. And how you say them matters tremendously. In fact, again, back to Eric Cassell, he said, similar to scalpels for surgeons, words are the palliative care clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words. I worked a lot with bereaved parents at St. Jude, and one of the bereaved parents told me, the way you tell the truth makes a huge difference to families. As long as you come in there and they know that you love them, it makes a huge difference. And I think about this poem by Emily Dickinson because I can't really just tell you exactly how to communicate. It's a skill. You can learn it. It's a learned process. And at the same time, it's an art. We have to tell all the truth, but tell it slant, success and circuit lies. Too bright for our firm delight, the truth's superb surprise. As lightning to the children eased with explanation kind, the truth must dazzle gradually, or every man be blind. Even more so when we talk about communicating with children, right? How do we involve children in this process? Well, we have to help them not feel alone, not feel isolated. And the communication really needs to be at the core of everything that we do. And when we think about this, one of the practice pearls I want to give you, this is a very, very good perspective piece on silence is not golden, communicating with children dying from cancer. They came up with these 6 E's, or they described these 6 E's of establish, engage, explore, explain, empathize, and encourage. And what they really come down to, I tried to summarize this in a way, and it's connect with the child. And again, that may not be my role as a physician, but it is our role as a team. And so we have to think about how to do that and how we can engage with that child. Another key concept is that we must be providing relationship-based care. I love this. So you all don't know me hardly at all, but when I went to medical school, nobody in my family had ever been in medicine before, and I really didn't know what I was doing. If I had to tell you what I was going to become, I thought, is there a music therapist in here? No? Okay, do your music therapists sometimes push a cart around and like have a guitar on their back? Okay, anyway, I thought I was basically going to be a music therapist, a child life specialist who wrote for amoxicillin. If you're a pediatric resident and that's what you think you're going to do, I'm so sorry, because that's not what happens in medicine. But that's literally what I thought I was going to be. I thought I was going to sing songs. I can't play guitar because I was so disappointed by medical school. But anyway, that's what I thought. I thought I would be, kind of like this Patch Adams person, right? And the beauty, though, of the work that we do is it is indeed through connection that we can make a difference. And what we have found is in studies, and this is in children with cancer, we have now found that if you have a stronger therapeutic alliance, you do have decreased decisional regret in the family, and you do have improved psychosocial outcomes. That's so cool, because it basically shows that if you're able to connect with patients and families with trust, this is a piece I wrote with a mentee named Brian Sisk. He's an incredible researcher now at WashU. And if you think about the concept of trust, it's something you have to work at constantly. And again, you don't know me very well yet, but if you think about it, as maybe investing into something, right? You're kind of investing into a relationship. And so when I think about investing, this is the piggy bank I think of course, a Pegasus piggy bank, but you have to be putting this in there. And so when we think about this relationship building and we think about this relationship and the experience that we need to create with our patients and families, we need to ask them things like, how has being sick been for you? This is a question that we ask every one of our families as we meet with them. How has being sick been for you? What do you think is the most common response? Like, what would you guess is the most common response? This is not more than half, but it is the most common response I'm about to tell you. What do you think? Just throw out some things. Terrible, thank you. Overwhelming, thank you. Scary, yeah. All of those are true. Those are much more common as a second response. Do you know what the most common first response is? Well, it started about 5 months ago and he had a limp. And I took him to the pediatrician, and when he was at the pediatrician, just kind of blew me off. We've so medicalized our patients and families that we ask them how they're doing. They answer with their medical story. How devastating is that? And then I have to stop them and I say, oh, thank you for starting and sharing that with me, but I've already talked to your team and I've already read your chart. I want to know what this has been like for you. As a person, seems tough. what's it been like? And then sometimes their shoulders will drop. Sometimes they'll look at me weird. They'll be like, wow, I haven't been asked that by a doctor before. How terrible is that? Literally, how terrible is that? We turn our patients and families into diseases, and that's what we do. We medicalize them. That's not the patients and families. That is us. We medicalize that. So we have to make sure that we address this, that we listen to them, that we connect. And I think this is a great video by Brene Brown, and we're going to even take it one step further after I share this video with you.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
What makes something better is connection. And the Harvard Business Review actually has this cool graph they put out. I feel sorry for you. Sympathy, I feel for you. Empathy, I feel with you. Compassion, I am moved by empathy to do something about it. And compassion makes a huge difference. It even impacts symptoms. I met this amazing patient, Emma. She had a terrible rhabdomyosarcoma, and she only had about a 5 to 10% chance of being cured. She was cured of her rhabdomyosarcoma and unfortunately then developed a secondary leukemia from her treatment. And she underwent, she was actually up in New York, a political science major, and she was up in New York, and she underwent transplant, and things were going okay from transplant standpoint, but she was having a lot of diarrhea, just terrible diarrhea, and she had kind of lost her independence. And when I met her, she said she was in a deep, dark place. She was having 3 liters of diarrhea a day, and she was having to wear diapers, actually. And so as in this process, I sat with her on Monday and Tuesday and Wednesday and Thursday and Friday, and I made all these phone calls and made all these suggestions and changes. And on Friday, when I met with her, she was like a whole different person. And I said, oh, Emma, this is great. I can tell that you're feeling better. And she said, yeah, I feel a lot better. And I said, well, how's your diarrhea? And she said, I still have 3 liters of diarrhea. But this is what she said. Talking to a compassionate listener made her feel like a new person. So much so that even though completely failed on the diarrhea front, she contacted the New York Times. And this is a paper for kids with cancer focusing on quality of life. It's out of the New York Times. She helped co-write this paper. And in that paper, she called me Superman. And I had nothing to do except sitting down and listening. This is how big a difference we all can make with sitting. I had failed. Like if you objectively looked, I failed at treating her diarrhea. And yet I succeeded in treating her as a human. And what we have to also do is we have to help families recognize the goals of care. And without knowing the goals, we're simply doing stuff to the patient. And when we think about these goals of care, it's really hard. For us, we might have done, nephrology for a long time or oncology for a long time. We might have walked with many families through this process. But the family, it's their first time. This is really tough stuff. They have lots of different decision points, lots of different situations. And we have to recognize that as we think through these goals of care, yes, there's one perhaps cure, leaving no stone unturned. There's the hope that we can live as long as possible, live as long and as well as possible, and living as well as possible. And what we have to recognize as we go through these is that there's also this evolving life and medical goals. Like, people have different things that they're working towards. And finally, one of the things that we have to also recognize is every patient and family has a dual goal of comfort. So when you think about, well, what can integrating palliative care bring to the table? We always can bring an outside the box way of looking at things to help people in their comfort. And so just think about us in those ways. And when we think about these decision-making and goals of care, these are all things from the literature that we've helped develop that make a difference. Things like suffering or relationships that the child has with others, being a good parent to their ill child. These are the things that then drive the goals. And the goals should drive the treatment options and decisions. But if you really think about it, that's not often what happens. That's not often where we're at. Too often we do because we can, without fully contemplating if we should. I'm going to pause here because you might have read that and said, oh, Justin thinks we shouldn't. No, that is not what it says. It actually says we should think about if we should. A great example of this is in the context of pediatric oncology. Very regularly, children with relapsed neuroblastoma have incurable disease. It's becoming where patients can live for a long time with this. But I used to use it as a little bit of a bellwether statement. I would say, when a patient has relapsed neuroblastoma, what do you do? And it was very common that someone would say, like, oh, we usually will admit them and give them ICE chemotherapy, ifosfamide, carboplatin, and etoposide. And I would say, oh, well, that's interesting. It probably depends on what their goals are, right? This patient has an incurable disease. Maybe that's what their goal is, but maybe not. And so we need to contemplate if we should. And also, a choice is only a choice if it is indeed a choice. Sometimes we come and explain things to families, and when they make a decision, we're pretty disappointed in that decision. Well, maybe if it was such a disappointing decision, we shouldn't have offered it. And interestingly, when you think about shared decision making, Doug Opel has this cool little model that we can, this is an entire talk unto itself. But this very first point here, does the decision include greater than one medically reasonable option? And if the answer is no, shared decision making is irrelevant. So if we think that there's one overwhelming proper decision, we should kind of put that on our own shoulders. And we should feel like we can help the family through that process. The next concept I want to share with you is probably not one you think about when you think about quality of life and palliative care. But the concept of hope is something we talk about all the time, every day, every single day, in our rounds or in our conversations. We in palliative care are talking about hope. In fact, hope is the thing with feathers. And I want to share with you another Emily Dickinson poem. Hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all. And sweetest in the gale is heard, and sore must be the storm that could abash the little bird that kept so many warm. I've heard it in the chillest land and on the strangest sea, yet never in extremity it asked a crumb of me. And hope is indeed the thing with feathers. It is critical even in seemingly hopeless situations. And hope helps us cope. It gives us a sense of purpose, helps with quality of life. It's a mechanism of balance. And hope changes across time. And I think nothing explains this better than one of my patients that I worked with. And this is another patient who is actually undergoing her third transplant. We had known her for a long time, for almost 3 years as a part of our palliative care team. And we went through the informed consent process with her. And the transplant physician very clearly told her that this transplant was an experimental transplant and that she would, even getting the transplant, still die of her leukemia. And yet, when I walked into her room, this was on the window. That is the window. You can see the window sitting there. You can see actually the some of the wipes there and otherwise. And when I walked in there and that was on the window, what do you think I did? I would love to tell you I didn't curse, but I actually did curse under my breath. I was worried. I was really worried, right? I was very concerned that, oh, no, she doesn't get it. That's our immediate response, right? When we see something like hope anchors the soul on her window. But what I've been taught by many chaplains, anyone here a chaplain? Yes, way to be. Chaplains have helped me understand that when my heart starts beating faster, when I feel like I need to leave the room, that's when I need to sit down. I need to lean in. And this is like advanced chaplaining. I'm not sure, this is probably one of your techniques too, but you sit down, lean in, turn your head a little bit, and you go, Slow everything down, lean into the moment. And that's what I did. I said, oh, sweetheart, it's amazing that you would write that on your window. Tell me about that. And she said, oh, Dr. Baker, I just want everyone to know how hopeful I remain. I said, oh, wow, thank you. Tell me a little bit more about that. I mean, what is it you're hoping for? And this is literally what she said. She said, I know I'm going to die from my leukemia, but I'm hoping by enrolling on this clinical trial, other children won't have to die from theirs. Oh, okay. So then I started to cry a little bit. Leaning into that moment, I said, is it okay if I take a picture of your window and share this when I talk about hope? Because you've taught me more about hope today than I've ever learned before. Hope changes, and what we have to recognize is that hope sustains every one of these goals. When we think about bereaved parents and hope, sometimes when patients have incurable disease, we feel like we use these phrases like denial and phrases like acceptance and realism and false hope. And the reality is very, very, very few families are in a context of like false hope. It's very rare. And we did a study, this is out of pediatrics, where we actually worked with bereaved parents, and they helped us create this painting. And you can see here in the left hand, the wind is blowing the petals of the child's life away. And at the same time, with their right hand, they're watering the hopes of their child's future life. It's beautifully stated by this dad. Partner with us and witness the transformative love of hoping for the impossible and the improbable, while accepting the painful reality that our rare and beautiful child is exiting this world. They can contemplate both of these things. And it's our job to help support them through this process. It's very difficult, but that's our job. Another thing that we have to do is we really have to think about facilitating legacy development and overcoming something. We were talking about this yesterday with Michelle, and I were talking about this a little bit in one of our meetings, this concept of mutual pretense. And this mutual pretense has been written about for a long time. And Myra Buban-Longener actually came up with that phrase when she, in her thesis, wrote about the private lives of dying children. And it's really about a parent and a child kind of in the same room that are both, the child is protecting the parent is protecting the child, and it becomes the 800-pound gorilla in the room. And we don't talk about these things. And we have to help our families and our kiddos think about their last wishes. And I want to share with you 3 stories. This first patient also had a rhabdomyosarcoma. It was in the back of her throat, and she was very close to dying. And we asked her what she was hoping for, and she said, I'm really hoping to meet my little sister. And so we worked with our ICU, we worked with our ENT docs, and we would not usually have placed a tracheostomy for her. And we didn't know if it was going to work. You can see here, this is a pretty fresh one. And so we placed it. We did a tracheostomy, and here she is in the delivery room holding her little sister. But I love this picture. This is when she's at home and we're caring for her with our home-based care team. And here she is, and you see the peace that is on her face. Or our patient in the middle, it wasn't his birthday, but he said, I'm hoping that I can have a party. And we said, oh, that sounds amazing. We're really good at throwing parties. And we said, what else? What else are you hoping? It's got to be Minions. It's got to be Minions. That's a cake. So that is a Minion cake. And as you can tell, I love cake, and I felt well loved that day. So it was a wonderful, wonderful day for me. Our last patient, I want to pause on her. She was a 10-year-old with osteosarcoma. And she worked very closely with our music therapists and also with our child life specialists. And she made a special song for every person that she loved. And this is the song that she made. We had to help her recognize that she was coming soon to the end of her life. And once she did recognize that, she made all these songs. I can just picture her singing that to her mom. And when I think about this concept that I'm going to share with you next, can you imagine if her mom didn't have that song? Can you think of the regret, or even the regret of this precious patient who wouldn't have gotten to sing that and share that with her mother? So we have to think about ourselves in the regret prevention business. And when we think about regret prevention, I think this is one of the most important things we do that we're not really taught how to do. It takes excellent anticipatory guidance. It takes connecting very much of the concepts that we've talked about. And when I think about it, I actually just saw The Marvels. Has anyone seen that yet? Okay, it was pretty good. I liked it. Anyway, you need to think of yourself as a superhero of regret prevention. Dr. Leonard isn't here today, and I know that she wouldn't necessarily want to be a superhero. She'd much rather be a rock star of regret prevention. You may not know it, but the Grateful Dead actually, which I think is a very appropriate name for what we're talking about, the Grateful Dead are out of San Francisco. And in their later years, Dr. Leonard was a backup singer for them. So that's also little known fact. So you can see her right there in the picture. But kids and families may have regrets about all sorts of things. And this is in the context of cancer-directed treatment. But the main thing to know is that if patients and families have regrets, if they have these regrets, they actually have higher levels of anxiety and depression. They miss more days of work. They have worse quality of life, and they even have higher mortality rates. So we have to realize that this is indeed absolutely vital work that we're doing when we think about regret prevention. And then would you raise your hand if you're involved in the grief and bereavement program here? Esther, you're not raising your hand, but okay. I got to call her Esther. Okay, so we also have to recognize that all of us have a role to play in grief and bereavement. And you might say, well, no, I don't really do that. Well, of course you do. You're a critical component of your family's journey. And what we found, and this is, again, a quote from a parent, I often say I have a hole in my heart and I can hear the wind blow through it. And I think that's such a powerful concept. But what they told us, these parents told us that there's a deep importance of strong and ongoing relationships, that high quality communication from you all to them is absolutely vital. This one's a little bit scary. Negative experiences in the hospital complicate their grief and bereavement journey. And that, again, is intuitive, but that's so important for us to be able to deal with. And then all of us have to recognize also that there's an importance of the institution's role. This is why events like the Day of Remembrance and our ongoing grief and bereavement program are so critically important. As we begin to wrap up on this section, I also want to tell you that a final piece of this is access to high quality palliative care is a right. It is not a privilege. And when we think about this, you'll understand this. We are not the fire after this video.
Hi, we got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there, it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department, and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
We're the fire department, not the fire. So this happened to us so much when we established our team at St. Jude, we labeled it the they are not ready syndrome. So we decided to study it. And we said, well, what if we go talk to the families? And we say, if you met with palliative care early on, would that be something that you would oppose? And basically nobody would oppose that. They would be happy to have us involved, even when we told them that part of what we did was deal with end-of-life care. They would have been happy to have us involved. And so this quote down here is actually, there was an editorial summary on this particular study, and it said, we, the medical community, are most commonly the primary barrier to appropriate integration of palliative care. And when we think about the avocado syndrome, you kind of think about when you open that avocado up, you're like, ooh, it's too hard. No, not now. Go and get right now, come now. Can you guys come now? Because it's the one, oh no, now it's too late. Oh shoot, okay. So partner with us because the World Health Association, in fact, the World Health Assembly resolution acknowledges that palliative care is an ethical responsibility and an ethical duty of healthcare professionals to alleviate pain and suffering. And I feel so grateful. In fact, this pin that I'm wearing is from when I was able to advocate for palliative care integration at the UN and at the universal health coverage component of this. And I was just recently actually at the very first working group for the World Health Organization on palliative care in Madrid. So the very first one, there were only 4 pediatricians there from in the entire world, and I was able to be there. So I feel really grateful to be able to advocate. But you all have to partner with us and recognize that access to high quality palliative care is indeed a fundamental human right. So as we think through and as we begin to wrap up, I want to come back and help you realize that what can you do? When you leave here, I want you to take better care of your patients and families. And I just want you to recognize that humble curiosity and holistically providing compassionate care is the absolute key. As we move into where I want to talk a little bit about our future state, I want to pause and recognize some true pediatric palliative care pioneers. Barbara and Harvey and the Pediatric Palliative Care team have done amazing work, been incredible pioneers in the field. In fact, I don't know if Barbara's online, but Barbara, if you are, these are your slippers that I brought here for you. They are koala slippers, so I have them for you. And Harvey, I brought you a book, and so we're gonna read this book as we close today. But I have those gifts for, and anybody that's been a part of the palliative care team historically, would you raise your hand? We have 2 here and hopefully many online. Thank you, Michelle. Thank you, Julie. Thank you, Harvey. Thank you, Barbara. Thank you to all the palliative care pioneers and champions that have done such incredible work here. When we think about the stages of palliative care development, the first stage is denial. The second stage is palliaphobia. The third stage is pallialia. This is a little scary stage. This is where there's some resources, but basically you're stuck and you're not able to grow. Next stage is palliactive, where there's palliative care is fully embraced, staffed, and resourced. And this is where most places stop, is saying, okay, now we're palliactive, we're in a good spot. But where we're going and where we're going to go, and I'm grateful Paul is here because he knows that I told him this in his office, but we're going to move into a place where we are looking at a pallia paradigm shift, where we're redefining the field, where we are willing to integrate palliative care as standard of care in the care of these children with catastrophic illnesses. And the way we're going to go about that is through this 3-tiered approach, where yes, we have this phenomenal consult team, and this consult team is up here in the front row with us. And after we finish today, I would encourage you to come, and if you haven't met us, please come up and spend some time with us. And we're moving to a point where we're going to have at least 3 teams, and Team A, Team B, and Team C. Team A and Team B will mostly be working on the inpatient services. Team C will be working in the ambulatory clinics. And then as we imagine things, we also want to move into a space where we have a robust home-based care program. This is shocking to me that here in the Bay Area, where there's more money than whatever, that there are really poor home-based resources, and we've got to do better. You know, we have programs like CORE that work in a beautiful way, but how can we link that with actual hands-on care in the community? And when you think about this second tier, we really need to be looking for champions. So let's say you are really interested in palliative care. Let's just call out Grant here. So Grant is interested in neurology. He wants to do palliative care and neurology. That's amazing, because Grant can then be our integrated champion into neurology. And we can imagine how we can then partner with him and come up with each of these stages. So Grant, when you think about your patients with neurologic issues, at the point of diagnosis, this is how we should integrate. And Grant's going to innovate on that space. Grant's going to be thinking about this, about research, and Grant's going to be partnering with our team to figure out how do we do this together. We did this with our bone marrow transplant arm, and this is a complicated slide, but basically from the point of diagnosis, we had, at the point of going for a bone marrow transplant, we had it mapped out of how we treat those transplant patients and how we integrate care. And we even then began doing embedded research projects with them. And we've published extensively on this, and I talk about this all over the world because it's such a beautiful integration model. To talk about it, this is kind of cool. The bone marrow transplant clinical director, this has happened twice, and well, at least he told me about it twice. It might have happened more than that. But families would say things like, well, I'm excited to go to transplant. This is going to be great, but I don't think we need to meet with the QoL team. He said, oh, okay, then we can't do transplant. Oh, oh, well, that sounds pretty good, doesn't it? That's how closely partnered we were. We were such a part of their team that if that family did not want to have our team involved, he said, they're a part of our team. It wasn't an us and a them. It was an integrated component of the bone marrow transplant team. And so when we move forward, also, we have to be thinking about this bottom tier. And I want you to think about the koala cares. And when we think about it, we're thinking about clinical, advocacy, research, education, and strategic planning. We're going to integrate throughout everything in the hospital here, all aspects of care. And if you're interested in palliative care research, come talk to us. You know, Shelby's here, she's leading our research team. And when we think about this, we're hiring a research director. So please be with us. We can't wait to start our hospice and palliative medicine fellowship program. Jess is actually doing clinical work right now, but she's leading us in that. And so this is a key component, is you being a part of this with us, that we're starting to ooze palliative care. And so as we close, I want to read to you, I mean, I think this is, Mary told me, Dr. Leonard, who is not here, she told me that you usually close your grand round sessions with the reading of a children's story. So, I'll go ahead and do that. This is a story, The Rabbit Listened. I'm going to recognize why I chose this in a minute. One day, Taylor decided to build something new, something special, something amazing. Taylor was so proud. But then out of nowhere, things came crashing down. The chicken was the first to notice. Cluck, cluck! What a shame. I'm so sorry this happened. Let's talk, cluck, cluck about it. But Taylor didn't feel like talking, so the chicken left. Next came the bear, not a koala bear, by the way. Gar, roar, how horrible. I bet you feel so angry about it. Let's gar, roar, let's shout about it. But Taylor didn't feel like shouting, so the bear left. The elephant knew just what to do. We can just remember exactly how things were. But Taylor didn't feel like remembering, so the elephant left. One by one they came, the hyena, hee hee, let's laugh about it. The ostrich, gulp, let's hide and pretend nothing happened. The kangaroo, tsk, what a mess, let's throw it all away. And the snake, shh, let's go knock down someone else's. But Taylor didn't feel like doing anything with anybody until they all left and Taylor was all alone. In the quiet, Taylor didn't even notice the rabbit, but it moved closer and closer until Taylor could feel its warm body. Together they sat in silence until Taylor said, please stay with me. The rabbit listened. The rabbit listened as Taylor talked. The rabbit listened as Taylor shouted. The rabbit listened as Taylor remembered and laughed. The rabbit listened to Taylor's plans to hide, to throw everything away, to ruin things for someone else. Through it all, the rabbit never left. And when the time was right, the rabbit listened to Taylor's plan to build again. I can't wait, Taylor said. It's going to be amazing. And as we think of building this 2.0 version of the Pediatric Palliative Care program here, I just want to tell you, this is how happy I am to be able to do this. I'm so excited to be here with you all, so grateful for this opportunity. And I just want to close by saying thank you to all of you for being here. And next time I will indeed wear the sumo koala outfit, but I thought for first impressions, I probably shouldn't. So thank you so much. I also recognize it is 9 o'clock right now. And so anybody that needs to leave, please feel free. We'll stay and answer some questions, but please, it is not disruptive at all. It's my fault for going 5 minutes longer than I had hoped. So please feel free to head out if you need to. Dr. Morvant, are there any questions online?
There are no questions yet online. But
How
if
about
anyone has
here?
Questions?
Anybody with any questions here?
Welcome, Dr. Baker. My name
Thank
is Allison Draper, and I manage our spiritual care department. Here at
Great.
Mrs. Packard. I'm wondering how you see spiritual care's role in palliative care.
Oh, it is one of the most essential components of what we do. In fact, I'm sure that many of these themes resonated with you, where you might say, oh my goodness, that works in the context of existential issues and otherwise. So yes, absolutely. I would say the rabbit probably is most closely represented by the chaplain program. But what I'll tell you is I think our program is interdisciplinary in nature. And I think each person, what we will do each morning, we will have these morning huddles as a group and as a whole, and we'll decide this patient is suffering this way, this patient is suffering this way, this patient is suffering this way. Who is the best person to attend to that? How are we going to approach that? And so with the chaplain on our program, we would then decide, okay, do 2 of us need to go? Do 3 of us need to go? Should we go independently? And so much of the work is therapeutic listening. So much of the work is presence. The ministry of presence is in the context of very similar to what we talked about with the rabbit. So I see, and then I will tell you that one of the most important things that we can do is have our chaplains teach us how to do this work better. Because I think the person that I learned from the least in my residency and fellowship program, there's 2 real people that I feel like I would have benefited tremendously from learning much more from them. And that was our spiritual care providers and our child life specialists. And so we will be integrating into all the educational components. And when I talk about discussing these things with residents, I'm talking about that as a team, including chaplains, including child life specialists, including us as physicians. So every aspect of what we discussed today needs to have spiritual care as a component of it. Absolutely essential and core to what we're doing.
Any other questions? There's nothing on the chat.
There's one more over here. Yes.
Can you just repeat the question?
Yes, the question is how to educate faculty. So now that we have talked a little bit as a team, and like you know me a little bit, so I'm going to say something that might be a little bit offensive. Is that okay? All right. So as palliative care providers, we are drawn to like the patients who are suffering the most. We're drawn to the people that are the most recalcitrant to change, right? So we're going to offer all sorts of educational activities where faculty can come and be a part of things. But those people that are most recalcitrant, that we really want to go and like, I want to teach, I want to do that, we actually realistically are probably going to need to leave those people alone. And the offensive piece is we probably need to let those people retire and go off into the distance. And we're going to repopulate the faculty here with people who come up through these educational training programs. We're going to be teaching communication training, teaching integrated palliative care techniques. That's going to be open to faculty. Becky, who stepped away now, I can tell you, as part of the pediatric residency faculty development, we've talked about coming there and helping with palliative care integration, communication training. A specific thing called Vital Talk is something that we have talked about integrating for faculty that want to be a part of that. There also, though, are things that we have to develop. So that bottom tier, I didn't talk a lot about this, but we have to develop policies. So whether a patient has a palliative care centric attending physician or not, there are some things that we just can't accept, that we're going to have to create policies around that, which basically will be a little bit of the stick. We'll have carrots, we'll have all sorts of ways that we can integrate and come in and help and be a part of things, but then we're going to also have policies that will just say this is how we do things. I'm thinking about things like end-of-life care. For instance, in speaking about spiritual care, a component of end-of-life care, and I don't know if this policy exists, it probably does, but if a spiritual integration of spiritual aspects of care is not already incorporated as part of the policy, which I bet it is, that would be something we would write into an end-of-life care policy, that regardless of who's caring for that person, that's just a part of what we do as Lucille Packer providers. Thank you for that question. Yes?
Justin, sorry, there's a couple on the chat really quickly, and I'm just going to combine them because I think they're interrelated. So one of the questions is, what if the clinician is feeling some negativity from the family about integration of palliative care? Do you sort of press them to get them to be more engaged and open? And then with that being said, someone else asked, should every patient in the PICU get a palliative care consult?
Oh, see, these are both
Whether
questions
a family wants it or not.
Yes, so they're very related questions, just as Dr. Morvant just asked them. So interestingly, when you think about things, most of the time people imagine something bad happening and then palliative care getting involved. that's when these negative concepts come in, when families are like, and then we have to come in and kind of like, well, we're not here because something bad happened, but we are, right? So the earlier we get integrated kind of answers both of those questions. I don't think everybody in the PICU needs to have a palliative care consult, no, but I think we need to work with the PICU attendings and with the PICU team to determine which patients do, and then it won't necessarily be a consult, it will be a standard operating procedure of how we address issues related to palliative care needs in the PICU. So those really go hand in hand, and we're really excited to partner with places like the PICU, with places like the CVICU and otherwise. That was a great question. Yes.
Hi, Justin. Carrie Rosbach with the Pediatric Residency
Yes.
Program.
Yay.
This is a comment more than a question, but I would just like to share that our pediatric residents are delighted to be guinea pigs in rolling out communication training.
Yay.
And special thanks to our second-year resident, Kate Paulson, who's working with you to build out our curriculum in pediatric palliative care for our residents. And as we've learned from other communication training, often what we teach the residents then trickles up to fellows and faculty. So we are delighted to help be the guinea pigs in that. So thank you for partnering with us on that.
Oh, we cannot wait to partner. My favorite story to tell about that is we started right away in palliative care with communication training of our fellows. And one of our fellows who became a first-year attending, she was attending on the leukemia service, and we were taking care of a patient approaching the end of life together. And a resident was trying to present this patient to this new attending, and she said, you know what, let me help you. Let me summarize and let me kind of model this for you. And I was sitting in the room and she began to articulate all of these beautiful approaches. And it was clear how much she had learned through her palliative care training. And she basically outlined it as we would as palliative care providers. She did such a beautiful job that I began to get emotional. And I almost started to cry. And so in my almost crying, I decided to giggle because I had to get the emotions out. And so I'm like, I went like this. And her name is Jamie. And Jamie said, Dr. Baker, are you laughing at me? And I said, I'm only laughing because if I didn't laugh, I would cry. And she said, why? And I said, you so beautifully stated that you stated that just as beautifully as if you were a palliative care clinician. And she said, well, what do you have to add? And I said, nothing. And I stood up and we walked out. She was so amazing at integrating the concepts that we had taught through this future partnership that we will have, that as now a new faculty member, wow, she was able to integrate all those things. So thank you so much. And we can't wait to use the residents as guinea pigs in a good way, good way.
Maybe just one more question. I'm aware of the time.
Yes.
And I think this is so important. And the question sort of leads to how are we going to be intentional about the growth of our team to represent so that we look like the families that we're serving, and how are we sort of being intentional about cultural representation specifically, in addition to, I'll just add, diversity, equity, and inclusion?
Yes. Well, I think that is such an important question, and I'm so proud to be in a department that leads with that. And Dr. Leonard leads by example. Paul leads by example. I think that we have, as an institution, that responsibility. And so, I'm just going to give you the very specific example of things like our clinician educator search committee. We try to have as many people involved in that look like our patient population as possible. We try to make sure that we're always leading with DEI lens, and we're thinking through these things constantly. And I would say that one of the most difficult things for us, clinically speaking, is to partner in the context of things like English as second language families. So families that we really struggle to connect with. And so, I don't know, is anyone here with interpreter services? I hadn't, oh yes, so Kim's right here. Who, and here, would I see someone else raise their hand or no? Okay, but this is such a vital part of our work, is how we connect. So this training has to extend to interpreter services. It has to extend to our volunteers. It has to extend to everything that we do, every aspect of what we do, because we have to make sure that we are integrating this into those families that right now are pushed a little bit to the side. And so we absolutely are going to have that as a part of everything that we do, every aspect of our hiring and every aspect of our clinical work, education, and research. So we went very long, but I just want to say thank you so much for your attention. Thank you for being here. It is amazing to be here together. So have a great day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.